Good afternoon. Welcome to this BMJ Future Health webinar on realizing the potential of virtual care. Thank you for joining us. We're going to be starting in the next few minutes, so please make yourself comfortable for a few more seconds. If you have already joined us, please say hello in the chat box at the bottom of the Zoom window and let us know where in the world you're from, what your name is, what you work on, and why you're interested in our topic today. We will start shortly. Okay, good morning, good afternoon, or good evening, depending on where you are joining us from today for today's BMJ Future Health webinar. My name is Malte Gerhold. I'm the Director of Innovation and Improvement at the Health Foundation, and it's my pleasure today to moderate our discussion. The BMJ Future Health community is a new community, and it consists of webinars, podcasts. We have a live event and conference in November, and the focus of the community is on innovation through digital solutions, because we believe that digital innovation is a key enabler for not just transforming the healthcare system for the future, but also for improving staff conditions and patient outcomes. But that also means we need to get the implementation and the use of digital innovation right. And that is partly what today is about. We will start our webinar with presentations from our three panel members, and we will then have a Q&A to have an opportunity for you to ask questions. When you do have questions, and you can start asking them throughout the presentations already as well, please submit them through the Q&A box function that's at the bottom of the Zoom window you should have in front of us, and we will pick the question from there. Also a reminder that this session is recorded today and will be made available afterwards to watch again and share with others. So today's webinar, our topic is realizing the potential of virtual care, how to use digital technology to bridge gaps in care for hard-to-reach patients. Virtual wards, as I'm sure you all know very well, have been a government priority for some years now, and they continue to feature heavily also in the thinking of our current government, and indeed are expected to feature in the future 10-year plan that is expected next week, particularly in the context of the shift from acute to community, and of course in the shift from analog to digitally enabled services. But we also know that virtual wards don't automatically work, and they don't automatically work for everyone. We have done polling at the Health Foundation ourselves that has shown that some community groups find it much harder to take advantage of virtual wards or care at home because of their family conditions or their ability to access it, or language and other situations. And other studies over the last month have also shown that virtual wards for conditions that rely much more on human care and contact, such as for frail elderly populations, for example, are much harder to implement and get right and get the benefit that we expect out of them than for some other conditions where the monitoring might be more straightforward at home for people. So this webinar today is partly about virtual wards and what they can do for us, but also about how clinicians can use virtual ward solutions to actually bridge the gap, particularly for hard to reach communities and patients, using virtual wards, using digital monitoring and digital inclusion. And it's also going to be about some of the policy solutions that we may need to actually overcome some of the workforce integration and digital implementation challenges to make virtual wards work and make them work for everyone. So with that, I'm delighted to introduce our expert speakers today. With us, we have Dr. Matthew Warren, who is consultant gastroenterologist at Northumbria Healthcare NHS Foundation Trust. And amongst other things there, Matthew is the Trust's clinical lead for outpatient improvement, where he's done a lot of work particularly focused on better connecting primary and secondary care to support people in the community. Secondly, we've got Catriona Wat, who is the area manager for the Mid-Argyll Community Hospital and Integrated Care Centre, where she has not just lived for many, many years, but also supported community care and community care improvement over many years, and has worked particularly with local GPs and social care colleagues to support and enable virtual wards. And third, we have Dr. Gerner Ang, who is Deputy Chief Clinical Information Officer at the NHS Leicester, Leicestershire and Rutland Integrated Care System. And he is also the clinical lead for the ICB on Home First and Urgent and Emergency Care And I believe Gerner Ang also is a GP. So he will bring particular perspective also on the digital and data aspects of making virtual wards work. Thank you so much to all three of you for joining us. So with that, let us move on to the presentations and introductions from our panel. Matthew, if I may start with you, welcome. Thank you for joining us, and over to you.
Great, thank you very much. And I hope you can see that screen. Walter, can you give me a thumbs up if you can see that screen?
Very well.
Lovely, okay. So thank you. My name's Matt Warren. As you've heard, I'm a gastroenterologist. I've been a consultant for about 20 years, and that's old enough to remember the very analog systems of GP and consultant interaction that existed at that time, paper-based referrals that wafted around the system, often led to long delays till patients were seen, and often in the wrong clinic. And now I think we've really tried to embrace more modern digital solutions. And what I'd like to describe to you is how we've tried to improve access to our entire patient population, improve their access to specialist care, how we've been able to improve it to, as I say, the entire population, but also how that's enabled us to start focusing on some more hard to reach groups, and how digital has helped us to improve the service that we offer to them. So let's see if I can make the technology work for us here. Okay, so beautiful Northumberland. I work for Northumbria Trust in Northumberland. We cover a huge area geographically, and we have a population of about 500,000 people, with a real sense of inequality, or a real inequality of poverty, of education, of rurality versus urban. And the consequence of that really before the pandemic was that we had lengthening waiting lists, largely dependent on where you lived, which hospital you were near to. Our analog service was leading to patients being brought into the wrong clinic at the wrong time, and really not leading to a service that we felt particularly proud to offer to our patients. And I've put that little cartoon in there of the waiting list in the top right-hand corner there, just to remind me that as we've gone through this process, we've started to see the waiting list not as an abstract set of numbers on a spreadsheet, but really as a population, a living, breathing population that's waiting and clinically deteriorating and trying to access healthcare in all sorts of different ways while they wait to be seen in secondary care, and really how the use of digital has improved our understanding of really what's going on outside of the hospital building. So I'll kind of come back to that as we go through. When I got interested in this, I had a very sort of single outcome that I was interested in, which was speed. I wanted people to be seen very quickly with an aspirational target of 4 weeks for routine appointments. I wanted to get rid of geographic inequalities across the trust. I wanted to get rid of the sort of lack of access to specialist care that people from deprived populations may have, because we know that they often struggle to engage with the healthcare system. So we were looking to achieve quite a few things, but speed was fundamentally what I was after. And I'd like to describe how we've used existing digital tools to help us with that, where we've got to, and what opportunities that has unlocked for us. Better value. I'll kind of come back to what I think this means in the outpatients space, but for us, this was absolutely underpinned not only by technology, but a recognition that technology only works as well as the people who operate it, and that medicine is fundamentally a human interaction. So we spent time building relationships with primary care. That was a very analog process, I'm ashamed to say, and I won't go into that in a digital discussion, but it involved me going out to primary care meetings quite a lot, sitting through some GP surgeries, just to try and kind of walk in another person's shoes, if that makes sense. But the main focus of today's talk will be about how we've tried to use the NHS e-referral system, and actually how, although a lot of people find it a very hot topic or a difficult topic, they don't like the system, we've actually found there's a huge amount of utility in it that we've tried to exploit for the benefits of our communication with primary care, but also to improve speed of access to our patients. And the sort of mantra that I really was attracted to was this idea of discuss with, not refer to. I really like the idea of all referrals or all patient pathways, if you like, being underpinned by a clinician-to-clinician discussion. And we know that everyone's so busy now, nobody can possibly work harder or carve out more time to spend together. We know that grand rounds have kind of died a death many years ago, and we found that digital platforms, ERS, was a great way of allowing a discussion, a dialogue between primary and secondary care to underpin our services and to try and underpin our improvements. And a little nod in brackets there at the bottom to the fact that, again, this only works as part of a wider package of care, and that clinical validation, waiting list duplication, management, all of that stuff is absolutely vital. And although I really don't like this idea of sort of buckets of work, you know, people talk about filling the bucket with new patients and then emptying the bucket with waiting list initiatives. You know, I don't really like that way of thinking about it. If we use discussions to try and limit flow into the system, unless we do something about the patients who are already in the system, then we're kind of missing a huge opportunity and a lot of clinical risk. You know, there are many patients who are already stuck in our system. This is not all about new patients. Okay, so validation and housekeeping. So what have we done? Well, we were early adopters of NHS e-referral processes, both RAS and A&G. A while ago, we realised in our experience that the difference between A&G and RAS, CAS, so pre and post referral, if you want to use those terms, the difference was arbitrary. And we found that our diversion rate, so the number of RAS appointments that we were returning with advice, was roughly equivalent to the number of advice and guidance referrals that we were accepting. I hope that makes sense. But what we kind of realized was that there was really no difference in what was coming into those two pots of work. I said I didn't like that term, buckets of work or whatever, and I've just used it there. There was no difference. And actually the functionality built into A&G was so much greater in terms of allowing that dialogue that we switched off RAS CAS a couple of years ago, and now we run everything through a single point of access through ERS A&G. Alongside that, we've engaged with our GP colleagues through a variety of surveys and regular engagement events, because clearly they're stakeholders and partners in this. And we've also recognised that a system is only as good as the people who deliver it. And we have moved away from things like consultant of the week model for triaging, and we now have a very selected group of job planned consultants who deliver this. This is not a way of working that suits everybody. You may have noticed a sort of drawing of a house and an axe on the previous slide, and this is because I think that kind of A&G and this digital dialogue can be both a constructive and a destructive process. If it's done badly, rudely, late, it can be a very damaging thing for GP consultant relationships, and patients will suffer as a consequence. If it's done well, then I think it is very constructive. It builds relationships, it smooths pathways for patients. So this is all well and good. Where have we got to? This is our very quick performance slide. We set out to see all our routine new patients within 4 weeks, having been at about 4 to 5 months at the start of this, and we achieve that 90% of the time, or should I say rather 90% of our patients are seen within 4 weeks. We have an RTT, for those of you that like this kind of thing, that's pushing 97%, no or few ASIs. And this graph here that says conversion rate, often NHS England talks about diversion rates. We talk about conversion rates, as in how many of our referrals do we convert to secondary care. It's standing at about 40% at the moment, with a short breakdown at the top, or sort of a small audit at the top from my last 100 odd cases, showing that I return about 55%, send about 25% direct to endoscopy, and only about 10 to 15% go to clinic. Compare this with a very analog service where all of these patients would go to clinic. So what can we do with these referrals, and how does digital help us to do it? Well, return with advice, you've seen, is my biggest outcome of triage, and I really want to emphasize that this should not be seen as a rejection of the referral, although I realize that's a politically sensitive topic, and GPs on the call may have very different experiences of advice and guidance to mine, maybe experiences of it done badly. So this should be a genuinely clinically valuable response that helps to move the patient's care forward. We know that patients can read the replies if they are uploaded through System 1 or EMIS onto the electronic patient record, and that was pretty horrifying to me when I first found that out. It made me worry what I'd said in GP letters. But now I love it because it allows us to communicate with the patient indirectly. We will ensure that we link patient self-management advice, that we link NHS guidelines, all that kind of thing. And we'll also do the same with GP responses. We know there's an absolute raft of great guidelines out there. How can the GPs find them? There are so many. Well, we can signpost that, and hopefully the next time the GP encounters the same problem, they don't have to ask us. We've kind of steered them in the right direction. So that was our kind of first level of A&R response. But as digital systems have grown over the years, and this is actually a picture of the screens I'm sitting in front of now, my laptop with the ERS running. The top left screen, I've taken all the patient detail out, of course. The top left screen is our Trust ICE results system, and the top right is the Great North Care Record, which is a kind of federated platform that will include Newcastle's records, GP consultations. So we run them all at the same time. And I don't think we feel we could do this properly without. So as the clinical information sources have grown, our ability to take more of a kind of oversight, if you like, more of an overview of the patient has really improved. We can see consultation behavior, we can spot previous investigations, previous referrals, we can see the absolute tsunami of psychosocial distress that comes through in a lot of our referrals. Just a chat there. We can see all of that, and that helps us to give GPs a lot more air cover in their management of patients. So we know that GPs are the expert generalists. We want to support them in that, and we want A&R to be to help build GP-patient relationships. And that sort of ability to proactively to offer proactive care, to demedicalize. We're starting to realize that a little bit more with a pilot that the elderly medicine team are running. They've adopted this model of working as well and got their waiting times down from months to days in many cases. And we're now using elderly medicine in a pilot as a single point of access for all frail and nursing home patients, irrespective of the problem that they have, just to try and use digital to sort of support a realistic medicine agenda. And similarly, we don't run any direct bookable services. The bottom two graphs show you that our endoscopy rates in the under 40s or the over 80s, considered low value endoscopies, a loaded term, but they are. Our line at the bottom is far lower than comparable trusts because we run everything through advice and guidance. Well, of course, sometimes we do astonishingly accept a referral, and then we write field notes, and these are stored digitally in the electronic patient record and in ERS, so that when a clinician reviews the patient, they can see the product of our review. We'll often sign up. We'll often signpost them for what to do with the result. For example, if we send someone direct to test, we'll say, to the GP, we will return this to you if it's normal, And this is what we would recommend that you do. So we try and get away from this idea of GPs referring someone in with a symptom, having a normal endoscopy, and then getting the patient returned back to them with a normal endoscopy, but exactly the same symptoms. The bottom graph just shows you that we use telemedicine judiciously where patients live geographically a long way from the hospital or have transport difficulties. And this just fits in with a sort of green agenda. The graph at the bottom and the miles less traveled shows you how many miles less traveled have resulted from our use of telemedicine. The Trust keeps this. Ask for more information. That's a third option. Better information gives better responses. So we'll often have a dialogue between ourselves behind closed doors. We might have a chat with the surgeons, with the haematologists, and go back to the GP with a consensus opinion. Wider impacts. I like this graph from the Royal College of Physicians. I'm pretty much on my final slide here now. From the Royal College of Physicians, defining outpatient value in 3 ways. And I think our ability to see digital platforms and communicate with them has given us that more of an overview of our population. It's helped us to see the population more than just the patient sat in the clinic in front of us. It's also freed headspace for us to start offering more services to hard to reach groups. And I guess that's kind of coming round to what Malta introduced us with. And these are things that I think we wouldn't have been able to do if we hadn't cleared the kind of huge backlog or waiting list that we had to focus on these hard to reach groups who by definition are hard to reach and require more time. We would have struggled to do that. So we now, on the bottom right, you see our trust inequalities dashboard. We run opportunistic liver screening and interventions to local prison services, into local drug and alcohol treatment centres, and now into one of our areas of highest deprivation in Wallsend. So final slide. Although I think we're all looking to the future and to AI, I think there's huge opportunity in existing technology. We haven't invested any money in this. No WLI, no new procurement. It's all been done with NHS technology. But digital is a tool to support clinicians and should never be the tail that wags the dog. It absolutely requires relationships and the right people to be using it. And I think it kind of encourages us to think about what specialist care could become, and that our model of outpatients is probably 20 years out of date. Thank you.
Matt, thank you so much. And I really like your final emphasis there. And in fact, your whole talk being much more about the relationship amongst care colleagues and with patients than the technology, which is just the enabler of that. And if you don't invest in the relationships and you don't invest in the collaboration and the way you think about it, your point around discussing with patients rather than referring to, or discussing with a colleague rather than, sort of handing off, making it a collective responsibility and ownership and leadership, how that changes the dynamic and the support care for people, not the technology that does that, it just enables that. Thank you very much. All right, so next up, we will be hearing from Catriona Wat, who's Area Manager for Mid-Argyll Community Hospital, and she will talk to us for the next 10 minutes. And Catriona, welcome. I think you also have slides for us, is that right?
Yes, I do. Can you hear me all right?
We can. It's a little bit quiet, but we can hear you.
Okay, I might actually just put my headset back on, put my headset off. Maybe a second. Hear me better now?
Yeah, that's better. Thank you. And at the moment, I think we can see a document rather than your slide.
This is my presentation, actually. I don't have.
Oh, okay.
Yeah.
Okay. No, great. Yeah. Okay. Good. Then we can see it. Thank you. Over to you.
Thank you. And just like to thank everybody for the invitation to come along today and talk about how we deliver health and social care to some of the remotest parts in the west coast of Scotland. So I think before I go over the presentation today, I'll just give you a bit of an overview of where we are. So if you look at the map of Great Britain and you look at the west coast, just directly west from Glasgow, that's where we are. We are right on the coast. We are a small town called Loch Gilphead, and it's within Argyll and Bute Health and Social Care Partnership, which is actually part of NHS Highland. We do have a community hospital. This is where I am based, and it's a community hospital and an integrated care centre. So within this hospital is right within the centre of it is the GP practice that serves the whole community here in Lochgilphead and the outlying villages. So people that come to this hospital get what we believe is an excellent service. They can get an X-ray straight away, they can get near patient testing bloods done straight away, and that type of service. The local GPs work very closely with us at the partnership to enable us to provide care out into the most remotest and the most vulnerable people out in our community. So I would urge you to take a look at a map and see where we are. Okay, so I've been asked to come along today and speak about the Mid Argyll virtual ward. So I'll just start from the beginning, how it all began. It began in November 2020, and that was not long after I came into post as the area manager here in the hospital. It was noted by myself as area manager that many hospital admissions could have been avoided and instead utilise the health and social care services available locally to care for these patients safely at home. I researched virtual wards, and following discussion with the local multi-professional team, it was agreed to trial a virtual ward. Initially, this meeting was face-to-face, and it was face-to-face in one of our bigger offices. But when the membership grew, we moved this onto the MS Teams platform. It was quite slow at the beginning, and that was about people trying to get the professionals really to engage and to see the benefits of that. And the membership started to increase. Members of the health and social care teams became more confident in bringing their patients and clients for discussion, which saw the patient numbers increase. I think just to say at the very initial stages, we very much just had GP, health and professionals from health, professionals from social work, but we didn't actually see the benefit of using the Scottish Ambulance Service, pharmacy, tech, and that type of stuff. And so the membership has only grown since the beginning, where we do have the ambulance service, pharmacy and tech come along, which has been a huge asset to us. As I said already, the medical input is from the GP practice here at Lochgilphead Medical Centre, which is situated in the hospital, and there are GPs allocated to the virtual ward every week. And so virtual wards, the definition of that is a safe and efficient alternative to NHS bedded care that is enabled by technology. Virtual wards, including frailty and acute respiratory infections. Virtual wards support patients who would otherwise be in hospital to receive the acute care, monitoring and treatment they need in their own home or place of residence. This includes allowing the patient to be cared for at home or to go home sooner. Virtual wards should be led by a named registered consultant practitioner, that is doctor, nurse, AHP or primary care GP with knowledge and capability in the relevant speciality or model, which includes the frailty and respiratory care. Our virtual ward is held twice weekly, and there has been discussions about increasing this, but it's felt amongst the professional team that twice a week retains a focus on the patients and allows time in between each virtual ward to assess and review the patient and report back to the forum. The patients are asked for consent to join the virtual ward, and an explanation is given to them regarding what this will mean to them and how they will be supported. And just another bit of information, virtual wards were introduced to reduce hospitalisations and or reduce the length of stay in hospital with early supported discharge by offering alternatives to inpatient care, improve patient experience and reduce the need to travel for care. MACHIC is an abbreviated term for the Mid Argyll Community Hospital Integrated Care Centre, and we have seen our admissions and length of stay rates fall since the implementation of the virtual ward. The patients who are delayed are normally awaiting a care home placement, which is something that we can't really control, and we are at the hands of the care home managers for that. So we do have issues in remote and rural areas, and that is that we do have patients who maybe become delayed in hospital. And because of our geography, so here in this town, we only have one residential care home, so patients or clients, people have to move a significant journey to access either a nursing or another residential care home placement, and that's what our stumbling block can be. Lack of care providers and staff in remote locations, and we are currently have 4 care providers, but it has to be, they have to be making efficiencies themselves as well, and so they won't go out to one of the most remotest areas to care for one patient. It has to be a run with other patients to make this more financially sound for them. The distance to hospital and the lack of transport to and from hospital if attending A&E, and that can be an issue for some people as well. And admitted patients may spend an extended time away from their family members. The positive effects of our virtual ward has reduced unnecessary admissions, it's reduced the length of stay in hospitals, it has improved teamwork and relationships, and I should have said here within the integrated multidisciplinary team, because we are an integrated partnership, and it's better outcomes for patients to remain at home. The Argyll and Bute Health and Social Care Partnership Strategic Plan for 2022-2025 states that within the plan we should have right care at the right time in the right place. Year 1 was enhancing multidisciplinary community teams to be responsive, flexible, highly skilled, continuously assessing with a re-abling and rehabilitation ethos and a high quality end-of-life care with the skills to provide simple care that currently involves a hospital admission. To consider models for community services with the aims of minimising different services and staff visiting people in community and improving the flow through the hospital. These objectives were achieved through the work of the virtual ward. So leadership and teamwork in rural advanced practice. Thought it was quite important just to put this in here. I know that's about the main differences between a leader and a manager. Leaders do not necessarily have designated authority. Leaders may not form part of the hierarchy. Leaders empower others, and leaders place emphasis on interpersonal relationships. It is important for leaders to enhance the growth of their employees and motivate them to be involved in decision making. The virtual ward locally follows relational focused leadership where all disciplines are equal and respected and everyone shares team ownership. I have a bit of feedback from members of the virtual ward here, which was quite interesting. So from our as part of our multidisciplinary team, we also invite along the inpatient senior charge nurse to come along to our virtual ward so that she's aware and the staff in the ward are aware of who we are looking after out in the community, just in case they happen to be conveyed to hospital or there's going to be discharges that the senior charge nurse would like to place on the virtual ward. So Emma Kemp has given her feedback, and the virtual ward gives insight to A&E and our hospital ward regarding the background and requirements of the patients who have been admitted to virtual ward. In the event they attend A&E, the staff will know what arrangements they have at home and whether they can be discharged from A&E safely without the need for admission. It also resonates in the ward and can provide additional safety netting on discharge. One of our GPs, who's also our clinical lead, Dr. Andy Barlow, he has stated the virtual ward unites all members of the MDT to provide effective, safe and patient-centred care in their own home. It reduces hospital admissions and increases patient satisfaction and autonomy. This was a quote from myself. The virtual ward is a professional forum where the skills, knowledge and expertise of all the professionals is recognised and respected. It is an asset to our local community. It is very difficult to set an admission criteria as one size does not fit all. It is agreed by all the multi-professional team whether to admit or not. In its first year, the virtual ward shifted the balance of care and often there would be more patients on the virtual ward than the community hospital. Data collected by our planning team demonstrated a reduction in admissions and length of stay. I would add, so this is another quote from our social work team manager, and we also have our social work team within the hospital as well, which is a huge benefit to us. I would add that social work as an agency has embraced the concept of the virtual ward here in Mid Argyll and as a key component of integrated working in partnership with local health agencies. The virtual ward is viewed as an antidote to what is often described as cultural I'm struggling to say that word, with the relationship between health and social care professionals as an integrated service or team. To this day, our virtual ward grows from strength to strength. We now have members of the Scottish Ambulance Service who join our virtual ward, and this also supports people to remain in their own homes. The membership for it is the community nurse team lead, and in their absence, another member of the community nurse team will come along, a social worker, occupational therapist, physiotherapist, a GP, pharmacy, technology-enabled care, senior charge nurse, the nurse specialist, Scottish Ambulance Service. This is healthcare support workers from our community team. And we do open up the invite to other teams, for example, the dementia service, mental health and other specialists, which could be the MND nurse, the stroke nurse, etc. They can come along and they can admit patients on to the virtual ward. And myself, I try and attend as often as I can. So what are our next steps for the virtual ward? So we want to produce a patient information leaflet, and we've been talking about this for some time, and we will definitely get to do that. And this will detail all the other information regarding the virtual ward, which will hopefully help the patients that we are looking after to see what we're doing for them. We're also going to create an urgent community response team this year. We're hoping to have that started in August. And that will be about trying to make sure that we can get to the patients, no matter where they are in locality, within a 2-hour time frame. This team will be a mix of nurses, AHPs and social work. And this at the early planning stage. This is at the early planning stage. And as I said already, we are hoping to have this introduced by autumn of 2025. Recognition. The Mid Argyll Virtual Ward was nominated and shortlisted for a Daily Record Scottish Health Award in 2024. We were shortlisted, but unfortunately we didn't come home with a prize, which we should have done. But the recognition across the whole of the Health and Social Care Partnership has been noted, and the Health and Social Care Partnership are going to try and replicate what happens here in Mid Argyll across the whole of the partnership. And just to finally add, the virtual ward team are a team of dedicated health and social work staff who are committed to the people they care for and the wider community, and without them this would not be possible. I don't know if I've added on to this presentation, but I actually do have another document which shows the data of what the ward activity was like, the length of stay and the admission rate before the implementation of the virtual ward. So I will forward that on to Charlotte and she can share that with you, because I had a most recent one where it's still demonstrating that we've got a reduction in admissions and a reduction in length of stay. That's it from me. Thank you.
Catriona, thank you so much. And I take away again the emphasis on how virtual wards have actually become a way of bringing staff and colleagues and patients together across lots and lots of different sectors and profession, and that's ultimately what is making the difference. I also found it important, the emphasis that you provided, that the virtual wards concept for you wasn't just about reducing admissions, but also created an opportunity to reach people in the rural community that might be much harder to or for whom it is much harder to access other healthcare services because of the local context and where they are living as a result of the opportunity that can be achieved for communities in their way by doing the care virtual. So thank you very much for that, and congratulations on the prize as well to you and the team.
Or not prize, the nomination.
Nomination. All right, still, that is what counts.
Thank you.
Good. All right. So last but not least, we've got Dr. Gerner Ang, who's Deputy Chief Clinical Information Officer at NHS Leicester, Leicestershire and Rutland Integrated Care, who will talk to us for the next 10 minutes or so on his experience and without slides. Thank you, Gerner. Over to you.
Thank you, and it's a pleasure to be here, and also a pleasure to hear of some of the experiences from colleagues from across both England and Scotland. I'm breaking the mold a little bit here. I'm going to go without slides, and hopefully the aim is to kind of start generating a bit of discussion to really shift us into the kind of the panel discussion, the question part of this discussion. I'm hopeful that most people here, as we've already heard from Catriona, recognise the value of virtual wards or hospital at home. I think we've all experienced now that there has to be a shift in the way that we deliver care. I think on reflection, and again, we've been doing virtual wards similar to Catriona for some years in Leicester. And I think one of the key kind of reflections that I've often kind of thought of is have we built virtual wards for the needs of the system and the organizations, or have we built them for the needs of the patients? And again, this might sound a little bit controversial, but absolutely, there is a need for us to provide stability for our system. We need more beds. There are no more beds. We can't build new hospitals or create new wards, physical wards. We know that demand is going up, so we have to think innovatively of how we can create additional capacity. But what then happens is you then start to build systems and pathways and design processes which are built around the needs of the clinicians, the system, the NHS in instances, and not always around the needs of the patient. And the reason why I want to really double down this, and I loved how Catriona mentioned that, this is their virtual wards really helped those who are in far and hard to reach areas. But the reason why I mention this is because there is a real simple principle in my mind, and I'm hoping that there's lots of leaders, as Catriona mentioned, so no official title, but people that can influence change in their organizations in this call today and listening back later, who can take one real core principle around designing processes. And Matthew alluded to this earlier. It's about designing with people. I know this is a digital conversation, but we cannot underemphasize the importance of not creating a new inequality due to digital technology. And so how do we avoid that? Quite simple, again, in my mind, you have to design your systems and your processes for the most excluded individuals in your system. And if you can do that, you then create a system which is inclusive for all. So I'd like to touch on some of my experiences or some of our experiences on a slightly different program. I was going to talk about virtual wards, but I'd like to talk about virtual care more holistically and slightly more broader, in fact. And so we looked at a project around how could we keep certain populations out of hospital even before they're unwell. Now, we know that perhaps the biggest challenge for most patients, certainly from a general practice perspective, is access. So Mrs. X becomes unwell, she may have a bit of a tummy ache, she may be feeling a bit feverish, and she may feel that, she needs to see a GP. So she rings up at 8 o'clock diligently, but unfortunately all the appointments are gone for the next day and she's asked to call back the next day. It's a story that we hear time and time again. We're trying really hard to try and change that system, but it's still a fact. And then the patient tries again the next day and is faced with the same barriers. And now things are actually getting worse. She's becoming more uncomfortable. Her fever's becoming worse. She's stopped drinking water. She may even have vomited. And that's the key pivotal point that an individual then may end up in hospital, because their next port of call is the only other open door, which is the A&E department or the emergency department. And so these patients we recognize are at very, very high risk of then having long stays in hospital, becoming quite unwell, and increasingly they could have very lengthy stays. And we know all the challenges that are associated with that. Every time you get admitted into hospital, certainly if you're frail, your muscles start to decondition, you become at risk of picking up hospital acquired infections. So we recognized we wanted to shift the model. The thing we couldn't do is we couldn't offer this to everyone. That would be the ideal thing if we could offer it to everyone. But so we had to risk segment which are our patient population groups that are the highest risk of ending up in hospital and having the most complications. And so what we did was we used a risk stratification tool called the Johns Hopkins ACG tool. So you may have heard of that. And we looked at the patient needs groups 9, 10, and 11. So these are patients that have frailty or they have complex comorbidities. And there's an overlayer of social deprivation in that as well. So you can really pinpoint the areas of population that you really want to work with, where you can kind of focus and hopefully get the best benefit. We work with a technology provider called Dockler to kind of collaboratively come up with a system that instead of the patient having to contact the healthcare services, if that patient started to feel unwell, they would be contacted by a clinical team. So really shifting the model as we know it right on its head, upside down. Now, the next question is often, well, okay, what about those individuals who don't have digital access? What about those who don't have access to the internet? And those of you who know, Leicester is incredibly multicultural. We've got massive pockets of deprivation, and we've also got massive populations of affluence. What about challenges with language barriers? So one of the things we did was to remove some of those barriers. So why not provide the digital tools and the digital means, the iPads with connected internet connections for those individuals, so we can completely remove that barrier. We've identified those individuals who we feel are highest risk. We engage with them. And we offer them this service, and then we offer them the tools to be able to engage with it. The next question was around, well, actually, are we over medicalizing people? These are individuals who, are absolutely well. Do they need their blood pressure checking every single day? Do they need their heart rate checking every single day? And the answer is no, they don't. So what we did was we used, again, readily available things out there. It's called the soft signs tool, and we just digitalized it, which effectively allows individuals to highlight when they are feeling unwell. And it's just very simple questions, such as, I'm in pain, I'm not walking as well as normal, I'm not eating or drinking as well as normal. So really, really simple things that might highlight a concern. When that concern is highlighted, an individual from a clinical team, and again, it's a multidisciplinary team, would contact that patient to further assess the patient. If necessary, offer some treatment. And if it was needed, a face-to-face appointment would be arranged for that individual. So the escalation of care could be directed by the clinical need that was appropriate for that patient, all supported by a senior clinical decision maker to kind of decide where does this patient best sit? Is it something we can treat virtually? Can we monitor this patient? So let's start Mrs. X on some antibiotics. Let's keep an eye on Mrs. X for 24 hours. If Mrs. X improves, great. If Mrs. X worsens, then actually let's do the next step in that assessment, which actually might be an onward referral into a virtual ward, for example. So we're still in its infancy, but we've already started to see some really, really positive benefits from this. We've seen that these individuals who, again, are high risk of admission are contacting our emergency services less. So there's been less ambulance call-outs for this patient population. There's been less ED attendances. We have still had admissions, so patients still have been admitted to hospital. And actually, I see that as a sign that this process is working. But what we've seen is that when these patients are admitted, they're admitted for a shorter period of time because we've caught their disease illness at an earlier point. And we've also seen a reduction in general practice contacts. Again, these patients know that if they feel there's a need, they will be contacted rather than them needed to reach out to the healthcare services. So I think, and kind of what my aim here today was to really do, and hopefully this is starting to generate questions again from all the people that are listening and watching, is to think first around the need of the individual. What is it that we're trying to achieve for our patient populations, for our citizen populations? Bring them into that discussion. We are now in 2025 and we are still, unfortunately, doing to rather than doing with. And really, really getting those principles right, having that voice at the table and understanding the needs of those individuals is so, so powerful, because then you can design the system for the people that we're trying to serve rather than just for the needs of our system to improve logistics or to improve waiting times or to improve capacity or whatever it might be. I was really fortunate to, and not related to digital technology at all, but I was really fortunate to be invited to an event organized by the Alzheimer's Society. It was an event held in Leicester, and they did exactly that. They reached into the community to understand what were the needs of the South Asian community with respect to understanding about memory loss and what can be done to support it. And it was really interesting because I found out a very simple thing, that music is great for those individuals with dementia. So what did they do in this conference, in this meeting? They brought Asian dancers in, Asian music, Bollywood music, things that were relatable to those individuals. But we wouldn't have necessarily known that that was an option if we hadn't had that discourse and hadn't had that conversation, hadn't had that discussion. So I'm going to kind of summarize there, and hopefully that will leave a little. I appreciate it might be a little bit less than 10 minutes, but I hope that will open us up to some interesting questions. And again, trying to reflect on what we can potentially achieve for those hard to reach groups, with the key message being that if we want to avoid exacerbating health inequalities as we're implementing more digital technology, we have to build for those excluded groups. We can only do that if they are at the table with us when we're designing the processes. Thank you very much.
Gerner, thank you so much. And I think what you've described there is really how we start to think about virtual wards beyond what we are doing today and beyond what the government priorities are. Again, how we start from the patient, the community, the care staff to some extent, and think about what do we ultimately want to achieve. I know from our own work at the Health Foundation, when we asked people about virtual wards, the really big feedback was that most people actually have no idea what virtual wards are. It's already a term that's a clinical term. It's about wards, sort of, etc. I think what you were describing is that to some extent we should be moving away from all of those terms like virtual wards, even hospital at home, sort of, etc. Because this is ultimately becoming it should become a standard default way of engaging with our communities, which is remotely or digitally and in very different ways and channels depending on what people need. But means we can reach them in a much better way and they get better care, including where they have previously been hard to reach. Thank you very much. Good. If you have questions, please put them into the Q&A box or also into the overall chat where I think you can contribute for that. We've got about 10 minutes left, so I was going to pick up with Matt and Catriona and Gerner a couple of points, and I've been thinking about virtual wards, listening to you sort of from three perspectives of some of the barriers to overcome and how you have been doing that. And let me give you all three, and then I'll let you each choose one that you respond to rather than all three. The first one, you all talked about the engagement with the patient and with the community and having that conversation first. And I was wondering if you wanted to talk a little bit about the sort of the type of conversation you needed to have to build that trust and build that relationship with a local community, particularly one that might be hard to reach or wouldn't naturally make a great use of, let's say, digital access or engagement. So that's sort of one. The second one is you also talked about how much of this is about the relationship between care colleagues. And again, I was interested in what you found some of your colleagues might have found most difficult in changing and adjusting their ways of working as a result of virtual wards and remote care. And then finally, there's obviously also the role of the center and how we enable this in a way that gives you and your colleagues the best possible opportunity to continue this ambition and extend it. And so if there was one thing in the 10-year plan that you'd really like to see and that would make you feel you can take this further in your ambition, what might that be? So community conversation, staff change way of working, or one thing in the 10-year plan. Pick one of those, and we've got about eight minutes. So if you have about 2 minutes maybe for each of your answers. Matt, can I start with you?
Yeah, thank you very much. I hope you can hear me again. So yeah. I guess the bit that probably fits more with what I've been up to is the relationship between primary and secondary care colleagues, so the interprofessional relationships. I think that was your second question. Was that right? So I think that's absolutely key. I think medicine is it's a profession built on relationships between patients and clinicians, between groups of clinicians. My sense would be that it's something that has grown. The gulf between primary and secondary care has grown over the years, and we have a fairly sort of unhealthy zero-sum attitude to this. It's our work or it's your work, and I think we all recognise that patients get caught in the middle of that. My experience has been, though, that if you go out to primary care or if they come to you, that those barriers get broken down very, very quickly. And I think there's just something about being in a room with somebody and talking to them, and they see you as a human person and not a signature on the bottom of a letter. That means that trust is built. This sounds all a little bit kind of wildly optimistic, but it's been my experience. And a GP said to us the other day, if you know somebody and that they're a reasonable person, you'll forgive them dropping the ball every so often. Yeah. And I think that's very true. But I think the converse applies, that if you don't know somebody and they write you a snotty letter, you then dislike them forevermore. If you don't know who they are. So we've organised a lot of shared learning events. We've got GPs into the trust. We've secured funding to pay GPs to come into the trust. And I'm afraid to say it's a very analog solution that we've had to adopt, because I don't think there is a digital way of building those relationships, but it wouldn't work without them.
Yeah, no, quite. And in a previous role where I worked in home care services and building bridges between home care and primary care, that was my experience also, that actually the personal connection, the introduction made the biggest difference, not the technology that was trying to use. We've had a couple of questions coming in, so I'm going to prioritize those. One, Catriona, that I maybe give to you is from Olu Arizakola, who's asking, how does continuous improvement work in this space? How often do you review your approach and system and improve it? Do you all talk to each other? Is there collaboration with others using similar solutions? How do you improve and learn also beyond your local area? Catriona, do you want to take that one? And then we've got one more, which I give to Gerner.
Yeah, thank you. I suppose for us improving and learning, it was a kind of growing feast really with our virtual ward, because I felt at the beginning I had the right membership actually. As the amount of patients coming onto the virtual ward grew, we then realised we were missing a trick here with having ambulance service. Ambulance service will convey patients to hospital that have fallen. Sometimes they're uninjured, but they're bringing them in at 11 o'clock at night because they didn't want to leave them at home. At 11 o'clock at night, there's not a carer in the house. The house might not be at the standard that the paramedic might have wanted, so they felt safer all round bringing that patient in. But actually, that would maybe be somebody that we would have on the virtual ward, and the ambulance service comes along and we can say they've got a package of care. They are a false risk. That's how they want to live, and just to be, confident that there is a social worker there, etc. So that's actually, I think, what Matthew was saying, is that it's actually reduced the amount of conveyance to hospital when that by ambulance, because of their membership within the virtual ward. So how do we make it grow? How do we learn by it? Well, we've learned, the data has proven what we've done in success as in not having these people come to hospital. Now, there is times when we do have to admit people to hospital. That's not defeat. That is because they need to actually come into hospital. We are not a hospital at home service, and we have to be very clear about that. We can deliver subcut therapies in people's own homes, but we don't have a licence as yet to do IV therapies. So there is a lot of interventions we can do, which stops that person coming in. And I think, as what Gerner said, people will decondition very, very quickly. And often we find when people come into hospital, families will then say, oh, I need to get a new bathroom in their house, or I'm going to be on holiday. These are the types of things that happen maybe more so in a smaller community hospital. And that's why we try to very much deal and manage with all of these things where it's appropriate in the patient's home. So the growing from it is that we've got the virtual ward, and I'm going to use the term nailed, because we've got that at a really good place. But what the question was for us is, what else can we do? So the virtual ward's not an urgent response. So that's why we're going to create an urgent response team, so that if, for example, Bill phones and says that his wife's fallen this morning and I no longer can cope with her, it's terrible, then it means that a physio or a nurse can go and see Bill, but also take somebody from social work to go and see him to speak about what he needs and what support we can give him whilst having that assessment, on his wife, etc. So that's what we're trying to hope to do, to stop these people from relationships breaking down, from, care home placements, that type of stuff. If we can intervene very quickly, we might end up putting these people onto the virtual ward, but we might be able to help support that then. So that's the growing that we are going to do from what we currently do at the moment. I hope that answers that question.
Yeah, and again, I really like to focus on the mindset of thinking about what else can we do, not just improve what we're already doing. Gerner, apologies with the time, but if I give you 60 seconds for this one, there's two questions around the implementation. One was specifically for you about how many iPads did you give to patients and care staff and the training, and then a related question about how long did it actually take to set up the virtual ward and process, how long did it take to build? So over to you for 60 seconds, and then I'll wrap it up.
Thanks. Can I take permission to sidestep the question, actually, because I think there's probably going to be more impact in if I may, and please feel free to reach out to me on LinkedIn for anyone who wants to pick up those questions. I've got no problem with answering them, but I think they're a bit more logistical. I just want to touch on your point around what the conversation should be with when you're having reaching into communities. First thing, and again, this is really, really practical. reach into the communities. Otherwise, if you're waiting for people to come to you, it's going to be the same voices. There's patient groups, PPGs are absolutely fantastic, but the hard to reach groups or the difficult to reach groups are the ones that we need to make the effort to reach into. The conversation you should be having is really, really simple. It should be about understanding what the problem is for that patient population, that cohort, that community. What are the struggles that they are finding? If you can understand the problem, you can then start to introduce the solutions. Don't jump to solutions straight away, and don't say, "Oh, we've created this. What do you think?" Well, it's already been created. You're just ticking the box and missing the point. Actually, figure out what is the problem for that community. What are they struggling with? So you can actually then start to create a more holistic approach to the overall treatment. So I just wanted to finish off on that because I think hopefully that's something really practical and tangible that people can take away with them, and again implement into their organizations as they go on this journey to digital transformation.
Good. Thank you very much. And thank you also for your offer for Jules and Rachel who asked the questions and others to reach out via LinkedIn, and that you're happy to answer that. That's really appreciated. I'm sure Matt and Catriona are as well if there are follow-up questions. Okay, that brings us to the end of our webinar. Thank you very much for our three wonderful speakers and their presentation and our discussion. Thank you for joining us. On behalf of BMJ Future Health, also to let you know that our annual event is happening on the 6th and 7th of November this year and is open to register. You've got the QR code there on the screen if you want to use it. It'll also feature discussions on particular problems posed by care staff or by patients and will be discussed that you can submit on the website until the end of July, which is also now there in front of you on the screen. And our next webinar will be taking place on the 25th of July from 12 to 1 o'clock, and we'll focus on bridging the digital literacy gap with Claire Diller and Kerry Roger. Finally, a big thank you to the sponsors of today's webinar, DNV and Learner Plus, but most of all, a big thank you to our three panelists and for all of you for listening and participating today. Have a wonderful rest of the day and weekend when you get there. Thank you and goodbye.